So I'm going to transition now to recurrent disease. As Dr. Moore said, these patients do develop recurrence, and there are a number of opportunities. We have 6 PARP inhibitor indications in recurrence. So I'm going to ask our panelists to kind of go through each of the PARP inhibitors in no particular order, but to talk about the maintenance opportunity after platinum-sensitive response, and then also the treatment. So I'm going to start with the Tom Krivak. Maybe you could talk about Niraparib and what the indications are for Niraparib in recurrent ovarian cancer.
Yeah, Niraparib, I think it was 4 years ago, 2016, New England Journal, great study. Basically 2 cohorts, a germline cohort and then a non-germline cohort, looking at platinum-sensitive recurrent ovarian cancer and then being treated with platinum-based chemotherapy and then receiving PARP maintenance again. And again, going back to let's look how we develop these drugs, platinum sensitivity, PARP maintenance, and looking at the 2 cohorts, again, we saw a really significant benefit with a hazard ratio of 0.27 in the BRCA mutated group and a p-value of less than 0.1. Again, going back to the discussion about the subgroup analysis going into the non-germline mutated patients, they broke it down and looked at BRCA somatic mutations, HRD, and then HR proficient. And when you look at the BRCA somatic mutation patients, very similar outcomes with the platinum-based chemotherapy followed by PARP maintenance with Niraparib. And then breaking down the patients who had HRD, they looked at the somatic patients with HRD, and then they broke out the HRD and excluded the somatic patients. Again, you saw an improved PFS as well with a hazard ratio of 0.45. And then going to the HRD proficient patients or HR proficient, you saw an improvement of about 3 months in that group. So it was a nice trial in that we saw a really nice prolonged response in our BRCA mutated patients. Again, responding to platinum sensitive recurrence, responding to platinum once again. But I think, again, as we're trying to build on our biomarkers, this really was a nice trial in that they had the exploratory analysis of looking at HRD, again, the Myriad test. And I think we could debate, you know, the absolute benefit of 3 months in the HR proficient group, what I used to call the triple negative group, negative BRCA somatic, negative BRCA germline, and HRD negative, kind of the most complex patients to treat, and that they seem to recur fairly quick. But to me, I think that kind of built on Oceans, which looked at bevacizumab, and now we're looking at this and building on using Nova and Niraparib for platinum-sensitive recurrent ovarian cancer. I think the other
and that the beauty of that, as Katie Moore said, is we had the integrated biomarker with platinum sensitivity. So we sort of underemphasized HRD testing, but HRD testing is much more valuable probably in frontline if you decide to do it. But Nova was the first platinum sensitive maintenance opportunity. And then tell us about Quadra.
And again, the thing that was nice about Nova, it expanded the indication. You went from BRCA mutations to all comers. And I thought Nova was well designed in that you guys had some safety nets to look at certain baskets of patients. And then Quadra, again, this is Katie's trial. And so it's kind of odd for me to be talking about Katie's trial because she's done so many good trials. But Quadra is heavily pretreated patients, HRD, BRCA patients. And I think it had screened about 700 patients, enrolled, I think evaluated 463 or so. But when you really looked at the label, what got indications was the BRCA mutated patients, the patients who had a BRCA mutation, regardless of platinum sensitivity in the 4th line, could receive Niraparib as treatment. So going from maintenance to treatment. And then if you were HRD positive, you had to have platinum sensitivity. And they had some very nice numbers with respect to, who responded, who didn't respond. And I think the platinum sensitive BRCA patients was right around 40%, platinum resistant was right around 25 to 30%. And then when you looked at the HRD folks, it was right around 25 to 30%. So to me, extending out how we can use Niraparib, and again, it changed the indication going from a maintenance drug, even though I kind of consider maintenance to be treatment maintenance in most of these cases, to actual treatment. So to me, I thought that obviously Katie's done a ton of good trials. This was another great trial to add to the options for our patients with recurrent ovarian cancer.
The beauty of Quadra, and again, thank you, Katie Moore, for doing that, is that it showed us the 3 predictors of PARP activity, right? Platinum sensitivity, okay, molecular signature, and then also number of lines of therapy. And we've leveraged those in Prima and Palace. So I think that was great. We also have Rucaparib, Tom Herzog. So tell us about Rucaparib and sort of what that offers to our patients.
Yeah, Brad. So we have really two indications for Rucaparib currently. And unlike the other PARPs, it's approved for recurrent disease, but for those patients who are 3 lines. So it's a 1 line earlier than 4 lines and beyond. It's 3 lines and beyond. Those, of course, are patients that have mutation. And then it has an indication based off the phase 3 Ariel 3 data, where Rob Coleman presented this, I believe, at ESMO in 2017, and then it became approved in 2018. And I think Jonathan Letterman and Rob Coleman were PIs on this particular trial, but randomized phase 3, similar to NOVA, but there were some differences. What was remarkable to me is across these phase 3s, how close the control groups were. So while there were some differences, it was still remarkable. So these were high-grade serous or endometrioid, greater than or equal to 2 prior lines of platinum. Had to have a CR or a PR to the penultimate platinum that they had right there. And then they also had to normalize their CA-125, which is interesting. They didn't have a size limit on their residual disease, which was a little bit different. So they had 564 patients, got randomized 2-to-1 to the Rucaparib or to the placebo. They also had this step down statistical analysis again, first looking at their BRCA mutation group. The hazard ratio there was 0.23. Then they went to the HRD group, where it was 0.32. By the way, their HRD was measured by Foundation's LOH greater than 16%. And then they went to the intent to treat population, and 0.36 as you get out there. So the medians change. You can see, again, the same effect, where if you look at the LOH low population, it was still positive, but the difference in the medians was 6.7 versus 5.4 months. So very much what we've seen in these first-line trials, different PARP, but very interesting safety profile, pretty much in line with what we've seen with Rucaparib from the study 10 and the Ariel 2, which would form their treatment label.